So when the Direct project was first spun up by ONC, the federal agencies were involved with that, and they were the key stakeholders for the Connect project at that time. So when we were doing our scheduling for development, it was intended that the release that would have occurred in January or beginning of February of this year would have had a significant piece of the Direct capability integrated into it, with the rest of it being integrated into the release that would have occurred 3 months after that. So by this time frame, we would have had all of the Direct infrastructure in place so that the Connect as a gateway solution could provide both the provider direct kind of connectivity and also the organizational enterprise level exchanges of health information. With the contract hiccup that occurred and the delays that resulted in that, the Connect work itself stopped, and then when we brought the Connect codebase over and started the Aurion project, the first release of Aurion, we focused on finishing up the core refactoring so that we would be able to have the flexibility to add new protocols like SMTP, which is what's being used by Direct, XMPP or AMQP, any of these others, and also adding other kinds of interfaces like RESTful interfaces. So we felt that had a higher priority given the limited number of resources, because the group that's working on now, it's an all-volunteer workforce that's working on Aurion. And so we were able to complete that core refactoring for the services that are in operational use. And now the what are called the emerging services are being refactored as we move between now and the next release in August and the release after that. So Direct is targeted as one of the things that the group wants to add in, but there was infrastructure stuff we needed to do to be able to make it more modular and easier to do these kinds of integrations for other kinds of functionality in the future. So we decided we wanted to do it right so that we would have better capability for adding
I
other
feel like
things.
we really have, between the RN project and between the Direct project, kicked off the right to complementary approaches to building this interconnected web of health data. You know, with Aurion focusing on the deep, meaningful, large system to large system, whether that's a hospital provider or a PHR or whatever, you know, with deep query, with distributed query kinds of capabilities and such. That's the kind of big use case, you know, the complex use case. Then with Direct, tackling the simple messaging protocols, right? The simple doctor to doctor, doctor to patient kind of communications and securing those. They kind of form like two edges of a square, right? That as they advance over the course of, you know, every doctor in the United States and the depth of health IT, eventually they can grow independently, but more and more they'll have overlap, more and more they'll have places where they reinforce each other, right? And the Direct project will whet the appetite of organizations out there for more deeper, more meaningful health IT interaction. I would hope that Direct, especially if it continues growing at the rate it's growing, well beyond the original pilots that ONC is running, and grows in a very voluntary way, you know, people wanting to do some simple things. Just like with Aurion as well, the federal partners might have funded it originally, but there's now lots of clusters of organizations using Connect for local area networking, right? That just in the same way that the internet kind of sprung up by local networks deciding to interoperate, you know, we'll see the same thing with health data. And I'm very optimistic about what that happens. 1 or 2 years is pretty fast, but my hope would be that within 5 years, you know, Americans start to expect that their health data becomes portable, that they can load things into a PHR, that they can share that data then with the new doctor that they go to visit because they moved to a new city or they changed providers or something like that. And that expectation will drive the rest of the health industry to have to modernize, to have to digitize.
And what if you look at this from a global perspective, internationally? Do you see any trends or things that this might tie into?
There's a lot of interest in this. I mean, a lot of failed health IT projects out there as well. The NHS in the UK spent £6 billion on trying to build a modern health IT system, and aside from a few little nuggets of goodness, really did not. I mean, they canceled the project. It did not. It substantially did not materialize into any value for them. And I think it's because they approached it as a top-down thing. Even countries that have national plans, national healthcare systems, the IT tends to be managed very locally at the hospital level, at the provider level. And so everybody needs this. And the protocols we've come up with, I mean, they do build on top of American health standards like HL7 and such, but they still fundamentally are international and could be international in scope in the same way that SMTP and HTTP are not, American technologies by any extent. It's an international network. Health data doesn't have as much of a need to be shared across borders, but we are seeing more portable workforces out there. We're seeing people, leave for different purposes, and you also see tourists who have to go to the hospital, on a trip outside of the country. They should have their health data available to them as they're traveling, and not just because it happens to be on a USB stick on their person, but because the other countries should. I think we should all interoperate in some way.
Medical tourism, I think, is a growing force. Medical tourism in the sense that people will go overseas to a center of excellence for a particular kind of procedure because it's known that they have good outcomes and it's a reasonable cost. For a lot of Americans, going overseas to get procedures done is simply to reduce the cost of getting that done if they're paying out of pocket. But it also, there's that factor of pockets of centers of excellence on various kinds of procedures, whether it's bypass surgery or heart transplant or what have you. So that, as that expands, and we see it in the U.S., where there's centers of excellence and people are traveling all over the U.S., there's a growing need to be able to have data flow to where the patients are getting the care that they need. So that's an example of not just because it was work-related or pleasure travel-related, it's because people are specifically going somewhere to a center of excellence for a particular kind of care. And there's definitely a need for being able to have their medical data there. Reduces the cost, you don't have to duplicate tests and stuff like that. So
I'd also believe that for population health purposes, being able to see trends around symptomic data, as it comes from one part of the world to the other, right? That if the more intertight our systems are, the more early warning we may get on the next big viral outbreak, for example, or notice that a particular new type of chemical used by the food industry is actually causing a lot more damage than we might have thought, right? The more that we can see these trends across a larger population set, the more data we have, the more informed we can be.